Mhm. Bom dia a todos. Well, it's a pleasure to introduce Professor Dirk Föll, that is here with us today. Professor Dirk Föll is a pediatric rheumatologist that works in the rheumatology and immunology department of the Children's University Hospital of Münster in Germany, where he works as a full professor and researcher, being biomarkers and systemic GI osteal disease, one of his main areas of expertise and research. Is also the new chair of the Euler Standing Committee on Pediatric Rheumatology, and a very active member in several working groups and in the pediatric rheumatology community in general. His talks and his opinions in the several working groups where I have the privilege to participate in some at least are always very inspiring, and he's also a very nice and funny person. So it's very easy to consider him already as a friend. And so it's really an honor to have you here with us, Dirk, and thank you so much for coming.
Yes, I hope this is working. So good morning, or bon dias, is that correct? I just tried to get that started here. Let's see. This one. And I really have to thank Philippa for the kind invitation to come here. I had a great day yesterday in Lisbon, actually. And as she said, I am from Münster and from the Department of Pediatric Rheumatology and Immunology. Together with our adult colleagues, we are a EULAR Center of Excellence. And to give you an impression on how many people we are 3 consultants in rheumatology and 3 consultants in pediatric rheumatology. So rather small, but with a certain focus on systemic diseases in rheumatology. Our adult colleagues, Thomas Paap, is an expert in osteoarthritis and molecular mechanisms of osteoarthritis, Martin Kriegel of lupus and microbiome research, and we are pretty much into systemic juvenile diseases. And so I prepared this presentation with much of a focus on SJA or Still's disease, as I realized while doing it. Was not on purpose. I apologize for that, but I hope it is also interesting for you. And this is what Münster looks like. So to the left, the principal market, which is really the living room of the city, and to the right, that is the castle, and that is the main seat of our university. So lecture halls and things like that actually are in there. And this looks not very much like Lisbon, I have to say, but there's a connection, because that is, as you know, Roger Schmidt, or I don't know how you pronounce him here. And he was 15 years ago the coach, or he started his career as a football coach in Münster. He looked a little different at that time, but beautiful, of course. And this is a football player from Münster, and he brought us from the 4th league to the 3rd league. And after he left for his worldwide career, we went back to the 4th league, and just this year came back to the 3rd league. And this is already quite something for Münster, actually. These are my disclosures. I have some research funding and connections to industry. And what I want to do today is, in the first part, speak about the current view of systemic juvenile idiopathic arthritis, or Still's disease, and then how this translates into management opportunities. And then in the second part, and that was the purpose of the talk, mainly to talk about biomarkers that could help us with managing patients with these diseases, or this disease, and maybe other diseases. The Still's disease, I'm pretty sure you know this all, of course, but to also remind ourselves always that the name in that disease really comes from Sir George Frederick Still, who more than 125 years ago was describing for the first time a sort of a rheumatic joint disease in children. So he's the founder of pediatric rheumatology, as we always say, although he was, mainly seeing adults. And in these 19 patients he described, 12 had something we today would consider consistent with the diagnosis of Still's disease, with fever, rash, hepatosplenomegaly, and arthritis. And then there are the ELA criteria. These are classification criteria we still use in pediatrics for juvenile idiopathic arthritis. This means you need to have a chronic arthritis of more than 6 weeks before you can classify a patient, which is a problem in a disease like Still's disease or SJA, because if you wait for 6 weeks until arthritis is present and then manifests for 6 weeks, this is quite a long time. But as you see, systemic arthritis is subclassified, or it's one subgroup within these ILA criteria. And now I think the next slide is very busy, and I already apologize for that. I just want to highlight 3 things, so you don't need to try to look this up. You can't do it anyway. It's not because of your eyes, it is because this is too small. But the current ELA classification criteria have the problem that they require arthritis of at least 6 weeks duration until you can coin a patient having SJA. This is for classification. This is purely for doing research and harmonizing patient groups in studies. It's not diagnostic criteria. The Yamaguchi criteria, often used for adult Still's disease, don't require arthritis for 6 weeks. They require arthralgia or arthritis for at least 2 weeks. So this is weaker. And we now, and Philippa is also part of this process, we are drafting recommendations for Still's disease with a group coming from EULA and PRESS, so from the pediatric and the adult side. And in these, it will be harmonized, and probably we will go back to the old definition of Still's disease, where you could have either arthritis or arthralgia. And this is much more consistent with something we could use as diagnostic criteria or tools to also come to diagnosis and identifying patients. We, in this group, and also I think in the overall research and clinical community, acknowledge today that adult onset Still's disease and SJA are pretty much the same in different age groups. They have certainly specific features related to age, but there are similar mechanisms behind it, similar pathways upregulated, activation. We can measure also of innate immune processes, natural killer cell deregulation. There is this predisposition to macrophage activation syndrome. There are similar clinical features, and we treat the patients the same, basically, and they respond to anti-IL-1 and anti-IL-6 therapy. What we have done in Germany is looking into a registry we had for 9 years. This was the AIDS registry, and AIDS is auto-inflammatory diseases. And Still's disease was within that collection of patients. And we had more than 200 patients in there and 35 in an inception cohort on juvenile arthritis. And we were interested in the features the physicians were recording in these patients. And as you can see, only a little bit more than half of the patients had arthritis. Many also had arthralgia, but what the patients had was systemic disease with fever, rash, and then laboratory signs of inflammation. So this would also much better fit actually Yamaguchi criteria than ELA criteria in almost half of these patients. What we didn't know really was, is this something that was a snapshot, or is this really also true if we follow up these patients? And then Klaas Hinze from our team looked into a broader collection of patients, into 262 patients now recently from the same registry. And he could see that indeed at baseline, 147 patients had arthritis and 115 had none. And most of the patients who had arthritis kept the arthritis. Some developed arthritis over time, but overall you can see that 85 patients, and that's 1/3 of this population, never developed arthritis. So arthritis obviously is not a major, or should not be considered the major sign of systemic juvenile idiopathic arthritis, with this somehow illogical, because arthritis is in the name of this disease, and Still's disease will be much easier to handle. On the other hand, we asked the question, could it be that there are two types of diseases? So one with the arthritis and one without arthritis. Could also be that this is not one disease, but one that is more in the JRA spectrum and one that is more in the autoinflammatory spectrum. And as you know, we now see these maybe opposing systems of innate immune dysregulation and adaptive immune dysregulation with autoinflammation or autoimmunity. Could it be that those patients who never develop arthritis have rather an autoinflammatory disease, and those who develop arthritis have an autoimmune disease? And these are two distinct disorders in a way. What we know from the past, and this is data from Virginia Pasquale's group from 2007, so 15 years ago, is that if we look at these patients and try to characterize them on a molecular basis, they look different. So they looked at, it's not a dramatically high number, but patients with SJA in the systemic phase and SJA in the arthritic phase. And they did a gene expression analysis based on RNA sequencing, and what they found was that they, of course, find in these disease differences in the patients, and that appears also quite logical because the systemic disease, of course, is very strong and gives a strong signal. What we did in 2019 was doing pretty much the same, but on a proteomic basis. So we looked for patients with systemic SJA in this autoinflammatory appearance and polyarticular SJA with the articular appearance. This is an image from George Frederick Still's initial description, and we can clearly see that he had patients with a long-standing disease and already contractures and severe damage. And these patients, of course, look different. Also, if you look at proteomic markers, we could measure in a serum as those patients with the autoinflammatory type. The problem is, or the question is behind this, is this really two diseases or is it a phase? So first we have the febrile phase, and this phase, as with George Frederick Still and the long-standing disease, then comes later, and it's not two different diseases, but patients go through these phases, but in a timely manner, so to say. And today, again, apologize for this, you don't need to look into all these very small names here, but I want to refer to that article that was published in Arthritis Rheumatology in 2019, where my colleagues Christoph Kessel and Christian Hedrich and myself, we tried to sum up what we know at the moment about the mechanisms that are in place in SJA. And we believe that it starts with an innate immune dysregulation where cells of innate immunity, granulocytes, monocytes, macrophages get activated. There's a lot of those cytokines we can target with biologics. IL-1, IL-18, the IL-18 inhibition will come, IL-6, and this all starts, and then there's obviously some shifting cells innately adaptive standing between those two systems, the innate immune system, the adaptive, like gamma delta T cells and cells like that. And then there's a lymphocyte dearrangement, and IL-17 and other maybe T cell peculiarities come into place, and this is then driving this articular autoimmune arthritis. And in a very recent publication, again, just if you want to look into it, Julia Kühn, who is now with Peter Nikovic in Boston, published in Arthritis Rheumatology, work from our group, where we saw actually that in patients with Still's disease, children with Still's disease, so SJA, we find autoantibody profiles that are pretty much peculiar. You can distinguish active patients from healthy controls, inactive patients from healthy controls, and not so well active from inactive SJA. So there seems to be an SJA, let's say, related autoantibody profile in these patients. And we also found that there's a skewing of T helper cells towards follicular helper cells phenotype. And this then also gives rise to plasmablast generation, and then autoimmune processes come into place. So very complicated, but if you want to look into that, it is certainly something we will have to consider in the future, because maybe therapeutic options will also need to be adapted if you find these autoimmune processes in patients. Then what was puzzling us very much with the Corona and COVID situation was transient autoimmunity we found in patients. This started actually with COVID. So in COVID patients and critical COVID patients, we found autoantibodies against the IL-1 receptor antagonist. And the IL-1 receptor antagonist, as you know, is doing exactly what's in its name. It antagonizes IL-1 receptor, and then IL-1 as a pro-inflammatory cytokine cannot work, and it's the same we use as anakinra in patients as a recombinant protein, and here it is the endogenous interleukin-1 receptor, and if you have antibodies against it, it can be a problem, as we could also show in assays. And what we found in patients with COVID-19 was that there is actually in patients with a critical disease a large proportion of patients in whom we can find autoantibodies against IL-1 receptor antagonists. And probably the reason for that is that they are transiently in these patients an additional phosphorylated isoform of the IL-1 receptor antagonist is expressed, and we recognize, our immune system recognizes this aberrant, not normal IL-1 receptor antagonist form, because only in patients where we had this anti-IL-1 receptor antagonist, or mostly in those patients, in this you do not see it because it was treated with antiphosphatase to get rid of this phosphorylation site, but in those patients you find an abnormal form of IL-1 receptor antagonist transiently. And then we were not so much interested in COVID. We were interested in pediatric disease, and we thought, well, there was this pediatric form of a hyperinflammation coming with COVID, the MIS-C or PIMS. So multisystem inflammatory syndrome in children, or pediatric inflammatory multisystem syndrome temporarily associated with SARS-CoV-2, two names for the same thing, but the one is more US American and the other one is more European. And we found that also in children with this disease, there was a proportion of children who had the same phenomenon. So anti-IL-1 receptor antagonist autoantibodies. And we could also find that in these patients, the level of active IL-1 receptor antagonist is low if they have the antibodies compared to those who don't have the antibodies. And if you compare with Kawasaki disease or SJA, Still's disease patients, this seems to be a particular problem in the patients with MIS-C and PIMS-TS. And why do I show you this? Because we continue with that, and we asked ourselves, could it be that in Still's disease, this is a problem in a proportion of patients, but we missed it. And we were looking into additional patients and compared them to rheumatic or inflammatory disease controls, lupus, vasculitis, rheumatoid arthritis, IBD, as you can see here. And indeed, we found that also in Still's disease, we find this process. So we find an additionally phosphorylated isoform of IL-1 receptor antagonist in some patients. It's a small proportion of patients, also compared to COVID or MIS-C, but we find it in some patients. And in these patients, we also find a reduction of the IL-1 receptor antagonist levels. However, we couldn't really prove that this is mechanistically making a lot of difference, because we didn't find differences in IL-6 or IL-18 cytokine levels, depending on the presence of the antibodies or not. So if this is really something that is leading to disease, we don't know, but it shows, at least in some patients with Still's disease, there's at least a transient autoimmune phenomenon like that. So our concept at the moment would look like that, I would say. At least my concept would look like that there's a phenotype shift over time. It's not two diseases. There may be a very short period of this hyperinflammatory fever syndrome phenotype that then shifts into the arthritis phenotype. And in the end, if we can't manage it well, and often we can't, then it goes into this phenotype where we already have the damage. And in children, we fear the growth deficit and, of course, also the destruction of joints. And the only patients I know who required joint replacement, they all had Still's disease. The problem is that the only group within that really fitting the ILAR criteria, the pediatric ILAR criteria, classification criteria, are these with the arthritis. And the medication we have were all approved using studies on that population. They all required as an inclusion criterion of patients fulfilling the ILAR criteria. And so that is a problem in the very late stage. There are also, of course, medication approved for the polyarticular cause JAA only. So you could use methotrexate, TNF blockers or so if you have the full articular form. But if you have no arthritis, then basically the only really approved medication is glucocorticoids and anakinra, and you could use canakinumab and tocilizumab. But again, these medications have not been used in the patients with the first phase. So, well, in a way, you could say we cannot use these drugs up front. And that is a problem because the trials leading to the approval of tocilizumab and canakinumab included patients with a very long disease duration. So the tocilizumab trial, the mean disease duration was 5 years. And in the canakinumab trial, it was 2.3 years. So this is certainly not the initial phase. This is long-standing disease, and they had all sorts of other treatments before, unsuccessful. And the responder rate is good, but it is not ideal, certainly. It's below 50% if you take response rates shown down there. So meaningful response rates would mean something like pediatric ACR 90 response. Whereas there's the experience of our Dutch colleagues in Utrecht. They use anakinra up front before glucocorticoids with a very short disease duration, and their response rate is much higher in these patients in the initial phase, which makes sense because you then also have the targets present you are treating. And this is in this initial phase, the innate immune activation with the cytokines, especially IL-1. And Peter Nikovic has drawn or published a cartoon like this. It's adapted a little bit, but this shows what we now call the biphasic disease model of SJA and maybe also Still's disease in adults, where you have the initial phase, this autoinflammatory phase, that then over time, if it is not blocked here, shifts into the arthritic phase with the polyarthritis, and here adaptive immune mechanisms come into place. And this has a time component and also brings with it a window of opportunity idea where we would say we have a window of opportunity in the first phase with targeted cytokine inhibition, and things get much more complicated later because you have a mix of many mechanisms getting into place. And this is again showing the experience of the Utrecht group as a proof of concept, basically showing that if indeed they use IL-1 receptor antagonist treatment upfront in this initial phase, they are very successful and they have a response rate of more than 80% actually in these patients if they treat early. So this goes towards a window of opportunity. To sum this up, what I wanted to show you is that SJA is seen as in a continuum with AOSD, and together I'm pretty confident that in the future we will call it Still's disease spectrum. It is a biphasic disease, bridging autoinflammation and autoimmunity. With that, it is very fascinating as a rheumatic disease because it shows us also maybe for other diseases how things can evolve into an autoimmune disease. There's a disease progression with the phenotype shift, and there is a window of opportunity in the initial autoinflammatory phase. This is the consequence of the biphasic disease model. Treat early seems to be better than treat late, especially with cytokine blockade. And what I want to now talk about is how do we translate that into clinical practice by use of biomarkers, and biomarkers specifically to facilitate the treat to target approach in Still's disease, early diagnosis, monitor therapy, and in the last part, predicting also relapses. So the treat to target idea, as you all know, was and is very popular still in rheumatoid arthritis in the first place. It was then transferred to other diseases. and Josef Smolin and others brought that up. And in a way, it is summarizing something that is very simple and was always in our minds, but in juvenile arthritis, it reads like this. So our primary target in anything we do in juvenile idiopathic arthritis is clinical remission, of course. And you could also come to an alternative target if this is not to be reached. And there's also something very important. It's only 0.8, but it's maybe the most important. But because for the patient, it is really extremely important that this is not a short-term honeymoon event, which could also be good, but it should be ongoing. It should be sustained, and there should be ongoing monitoring to make clear that the target is maintained. So we are talking about remission that is lasting long, maybe forever. And this is the ultimate goal. And how could we use biomarkers in there? This is from the original publication of Angelo Ravelli and Josef Smolin on the treat to target approach. And this was published by my colleague Klaas Hinze on treat to target in juvenile arthritis a little bit before. And this shows different targets. So we have a target in the beginning. We want to induce remission on medication. Then there is a maintenance phase. And in the end, we want to also achieve remission off medication. This is then the 0.8. And then we need to consider withdrawing therapy. This is the logical consequence. And in that, if you see here on the y-axis, the disease activity, on the x-axis, the time, there are different phases a patient is going through. And at different phases, we have different options or, let's say, ideas where we could use diagnostic markers or biomarkers. And the first would be a diagnostic marker enabling early start of therapy. So in patients in whom you are not so sure if it is the right patient, if it is Still's disease, and sometimes differential diagnosis is not so easy, I will come to that. A marker would be interesting to have because then treatment could start early, and this is better, obviously. Then we need to have biomarkers helping to monitor therapy. Ongoing monitoring should be in place to see if we are on track, because this dashed line is the clinical manifestation threshold, as we say. Everything above you can see. So the patient is sick, obviously, rash, fever, arthritis, or whatever. And below this, you don't see that. This is our concept. There's a subclinical disease, something smoldering. And here you cannot be that sure. And if you then taper treatment and the patient gets disease activity again to a point where you then see it, it would be good to know before, because maybe you could prevent getting a relapse. And in the very end, it would be very good to have biomarkers also to not only monitor and decide about change of therapy, increasing or tapering, but also to, in the end, then a decision in whom we could stop treatment. So this is the idea. This is where we see in a treat to target concept, one could make use of biomarkers. And this is also related to the fact that we see barriers to treat to target. Treat to target sounds so easy. I mean, we want to have remission and this should be sustained. In clinical practice, and we also have data from registries and initiatives behind it, we see that most patients are not treated following treat to target protocols. They are outside, individual treatment decisions and so on. And one reason is that there's a delayed diagnosis. So it's too late. And there's a lacking tool for tight monitoring. So we would like to monitor the treatment, but we can't. And also these step-up treatment recommendations are still problematic, that we start with a very mild, let's say, treatment, and we increase when complications come into place. And this is the opposite of using a window of opportunity, where we would treat upfront with the best treatment option we could have and not wait until problems occur. So the biomarkers, there's pretty clear a need for biomarkers, especially in a systemic disease like Still's disease, because we can measure these mechanisms I showed you in the beginning, auto-inflammatory mechanisms, adaptive mechanisms. I showed you IL-1 is present, and autoantibody profiles come into place. So we can measure things, but why don't we do that? And this is because of the translational gap, in this case in Still's disease biomarker research, but it is in any disease. So actually in discovery, if you look into PubMed and look for biomarkers in Still's disease, you see actually exponential curve. It's not so well seen here, but there are more and more publications every year on biomarkers that are discovered for Still's disease. But if you then see how many of these are validated and look for validated biomarkers, the numbers are very small, actually. They are at most here maybe 10, but it is really a very small number of markers that can really make it into a validation. And we have to mind the gap here, because this is, of course, extremely important. Our colleague Faika Gohar published in Arthritis Research and Therapy in, I think, 2016, a paper where she reviewed biomarkers in systemic juvenile arthritis and tried to see if there are, which are the best validated markers in the end. She identified 68 biomarkers, but most of them were investigated by only one single research group. So there is no, let's say, independent confirmation by another research group on the same marker they have discovered. No biomarker scored 5, and you see the scoring here, so it should be readily measurable by more than one independent group, discovered by more than one single method. So it's not enough to have an ELISA. You should also be able to measure the protein or whatever you look at with a second method. It should be a reproducible assay. So everyone should use it with a protocol, should be able to use it with a protocol, and it should be validated in a validation cohort. So it's no use to have a discovery cohort and then you discover something in there. It needs to be validated in a validation cohort, in a second cohort of patients, if your result still holds true. And actually, there was a lack of biomarker validation in independent cohorts. So no biomarker scored 5, but IL-18, S100A12, S100A9 scored at least 4. So they were at that time pretty much investigated. And as we are working on S100 proteins, I want to show you what that is. So what you cannot see there in the title is that is S100 proteins as DAMs, as damage-associated molecular patterns, also called alarmins or danger signals. Actually, the S100 family of calcium-binding proteins has 23 members, and not all of them are alarmins, but there is the subgroup of calgranulins, and these are expressed in phagocytes, in cells of innate immunity, granulocytes, monocytes, and as you remember, in Still's disease, these are the cells getting activated up front. And what you see here actually is a vessel in a vasculitis patient, and these are granulocytes, and in red stained the S100, in this case S100A12, and it is then obviously packed in these cells, but it is also secreted where the cells get in contact with the endothelium, or it is deposited there, let's put it that way. And we have candidates with complicated names, therefore I want to really introduce that to make it clear, because it's often a matter of confusion. There's a complex of S100A8 and S100A9, and it's not my idea to call it this way. It was the Calcium Society saying these are the S100 proteins because they are soluble in 100% ammonium sulfide, and I don't know, this is history. But this complex is also called myeloid-related proteins 814 complex, already complicated, so you find it in the literature also as that, or calprotectin. And as calprotectin, it made a real career in IBD research, because this is also measurable in stool and is now really, I would say, a standard test in IBD for stool tests for inflammation. And there's a second candidate, or third, S100A12. It's not in complex with these others. It's called calgranulin C. It is a little bit more specific for granulocytes. The important thing is they are not only biomarkers, they are not only expressed in these cells, but they have an alarmin function. They probably have a homeostatic role intracellularly. We don't know for sure if it's just a calcium buffer or something. But once extracellular, if they are released or secreted, they bind to toll-like receptor 4 and activate target cells by that. And they are very potent activators of inflammation via toll-like receptor 4. And what Michael Frosch already published in 2003, so this is really 20 years ago, was that you can measure these proteins not only in stool, but you can also measure them in serum or plasma. We prefer serum. And with a very simple ELISA, what he found at that time was that in systemic onset juvenile arthritis, these levels are very high, also compared to infections or other juvenile arthritis forms. He found that especially with fever, but also in a relapse situation, he found very high levels. So that's 20 years ago. And then 2009, he compared to other diseases which we found were also differential diagnosis, because they can occur in situations of fever of unknown origin. And sometimes in Still's disease, in the initial phase, if there's no arthritis, it is a fever disease with a rash, and you really don't know what you're dealing with. It's fever of unknown origin. And he compared systemic JAA also with autoinflammatory disease like NOMID, so CAPS, and leukemias, lymphoblastic or myeloid leukemias, and healthy controls. And he found that in opposite to CRP, this marker could actually indicate SJA patients within this group of patients with systemic disease of unknown origin. And after we published that, we received a lot of samples, actually 10,000 samples for all kinds of indications in our lab. We offered this test for free for all German hospitals and simply wanted to do research on a research basis. And there were 1,900, you can read it, samples received within 6 years with suspected SJA or patients with fever of unknown origin. 1,600 then really fulfilled the criteria of fever of unknown origin after excluding genetically proven autoinflammatory diseases, and 360 roundabout really had fever and were without therapy in the end. And these were used as a validation cohort. So to overcome this translational gap, we thought this is a good validation cohort in which we could check whether the initial discovery data would hold true by looking into the different diseases behind these patients in the end, recorded by the physicians after 1 year of follow-up. And what you can see here, that there's a large overlap. So to the left, that's Still's disease, SJA. The second is infections. Then there's autoinflammatory diseases, except FMF or genetically proven disease. And there's a mixture of different things. And there's an overlap, but if you come above a certain threshold, then both the S100A8, A9, MRP814, or calprotectin in serum is identifying patients with SJA. It is very unlikely if you have levels that high that you have something else than SJA. And IL-18 is also helping with that regard as a second marker that can be confirmative, because it is really very low, for example, in infections compared to SJA. And it's not 100% distinction, but we found with analysis, receiver operating curves, and sensitivity specificity analysis that the sensitivity can be above 90% and specificity almost can be 97% if you use MRP814 and IL-18 measurements in different combinations. If one of them is elevated, sensitivity is 92, and if both are elevated, then you get an increase in specificity and you can be very sure that you deal with this disease. And so when we published that, there was an editorial saying this is the first validated biomarker for SJA, but it needs to be transferred into the clinic. It is a very long way to go, really, to do that. And also they said there needs to be more hemato-oncological diseases tested to be sure that it is really specific. So what we do now in our clinic, we don't pipette ELISAs anymore. So we transferred this test onto, in this case, it's a Roche Cobas 502 machine, but it's a standard laboratory instrument, and we have a turbidimetric assay coming from Bühlmann in Switzerland, actually, who developed this kind of assay that can detect the protein complex in very small amounts, like 5 microliters, and can be implemented onto the normal into the normal machine, so it can run this analysis on demand, on request, just while it is doing also CRP. And we were using that to reconfirm that this is now not a new cohort. It's the same validation cohort. It's just a different method now. It's a method that could be used in any laboratory over the world. It's a commercially available test. Of course, it costs money, but in theory, it could be implemented in any laboratory setting. It's easy to do, and it gives the same information. It is high in SJA. It is high in infections, but there is a cutoff where you can be pretty sure that you have SJA. We also tested a number of patients with leukemias to ensure that also the differentiation versus leukemias is holding true, and we implemented a cutoff for this assay, and we believe that this is a way to really implement it into clinical practice. And there's a preprint available. You find the link down there, and it will be published soon. So to sum that part up, there is this significant translational gap, a lack of validated biomarkers, markers allowing early SJA diagnosis. At the moment, the best candidates are S100 proteins and IL-18, maybe in combination with others. But it needs to be practical, and the first validated marker really ready for routine use would be this serum calprotectin, or S100A, A9, or MRP-814 I showed you in the past. Now, time is running up, but I want to, at least in the end, very briefly show you one aspect of the withdrawal. So what we found in terms of monitoring is that patients respond better to treatment the more intense the inflammatory signature in the beginning is. That makes sense. So we find a difference between the systemic phase and the articular phase. I already showed you that. But what we also saw in patients treated with IL-1 blockade and canakinumab, in this case, we could separate these patients into patients who had a super response, a 100% ACR response, and remained inactive over time. And this is actually the patients in blue here. And we find that these patients had much higher levels of IL-18 than those who in the end did not respond that well. You can see that there, they all end up at the same level. And in CXCL9, this was different. And this was published already in 2021. And this is also something we consider interesting for the future. So could it be that we calculate ratios, and this is protein measured in serum between IL-18 and CXCL9? And in those patients who have this very high ratio, so much higher IL-18 compared to CXCL9, despite the fact that IL-18 via interferon gamma should increase at CXCL9. So there's a disbalance, obviously, between in this link that this may relate to the fact if you respond or do not respond. If you don't find this ratio high as that, it is rather unlikely that you would respond to IL-1 blockade. And then maybe you need something like IL-1 blockade plus steroids or plus T cell inhibition or something else. And then the last question, very briefly, is this relapse or remission aspect. And here, Dirk Holzinger published already in 2012 that indeed we had patients with a flare who are almost as high in this case, again, MRP-814 levels as at your onset. But what he then realized was that there were patients in inactive disease, and it looked as if these patients were also not looking exactly like healthy controls or healthy children. And sorry, other way around. And what he then did was looking back into these patients, and he found 26 patients that were all considered clinically being in remission, and they come on a 3-month regular basis to the visits. And those who remained in remission always had low levels of this marker. They were clinically inactive and also had a low level of this marker, whereas those who then had a relapse already had elevations above normal. This dashed line would be the normal level at that time. And so obviously, if you would be able to measure this protein in a patient who otherwise looks fine, also has a normal CRP and ESR, this could relate to the risk of later develop a relapse. And he was also putting that into a survival analysis showing that this marker could work for that. I have to say that there is very little really promise to translate that into validation, because studies testing withdrawal strategies are very complicated and there are not a lot of examples. This is one, this is for canakinumab. They did a withdrawal trial. Novartis was doing that. They looked into 2 ways in a randomized fashion of dose reduction or dose interval prolongation to then come to the step where they could discontinue canakinumab, and actually they were able to do that in a smaller proportion of the patients. And there was a slight difference between the dose interval prolongation and the dose reduction arm. So the dose interval prolongation seems to be worse than the dose reduction arm. But this is really one of the very few examples of studies doing that. We are currently analyzing biomaterial out of this trial. We are looking for gene expression profiles. I don't want to go into that. This is more technically that we can see that active patients, a lot of genes are different, mostly upregulated in active patients versus inactive patients. This is rather to show the concept, whereas inactive and healthy controls do not differ in our hands. This is total RNA sequencing, and this is work ongoing, so I cannot really go into detail on that. But there is obviously, we may find markers that show that non-successful tapering. So if you are not able to taper and stop treatment, that there are certain genetic markers, RNA expression markers that could show you that this is the patient with a signal showing you that this will not be successful. And there will also probably be differences between those 2 arms, the dose interval prolongation and the dose reduction arm, but this is too early to really say. So I want to sum that up. Also the third part, which I now did very fast. So there are elevated markers of innate immune activation. If you find them, it is more likely that a patient will respond to cytokine blockade. This makes sense, of course, because then the mechanisms are in place you want to target. There is this disbalance of IL-18, interferon gamma, and CXCL9 in their axis, and this seems to affect the response to IL-1 inhibition. Currently, we don't know exactly why. There are biomarkers, relative differences, so even small differences in some markers may indicate subclinical disease activity, and that might impact the risk of flares at the S100 proteins as proteins we are investigating. And despite all that, I would say that stopping treatment, and especially biologics, remains a challenge, even if we use biomarkers also in our hands. Of course, this does not work always. So as a very final conclusion, if you want to use biomarkers in SJ and Still's disease, I think there are 3 points where it is really meaningful to do that. And if it is available, I think you can't do without. The first is confirming diagnosis in patients where you have differential diagnosis you cannot rule out, and you don't want to wait and waste a lot of time in your differential diagnosis. The second is then, if you want to have extra information before starting medication, so there might be different signatures showing if a patient is better with glucocorticoids, with IL-1 inhibition, IL-6 inhibition, IL-18 inhibition, or something completely different, or combination. But this is for the future, I would say. Whereas a detection of subclinical disease activity before stopping medication, I would say this is something where we have data already, and this can be taken into account into our considerations in patients. And this is the group. So we go actually into the snow once a year. You cannot see that really, but all white is snow. And the data I was showing you was primarily from Christoph Kessel, who you can see there in the back, and Tanja Hinze. I want to thank them, and I want to thank you for your attention. I'm happy to take questions. Thank you.
Okay, there's time for questions. So I don't know if anyone in the audience has some question. Well, while you are still thinking, I would like just to make a comment, because we have many adult rheumatologists in the room, and you showed data mainly, of course, regarding systemic JA, so the juvenile onset of Still disease, but there's a growing data as well for the adult onset of Still disease, about the use of these biomarkers, especially calprotectin and IL-18. Also, the utility for the diagnosis, for the differential diagnosis, as you said, but also for predicting flares or discontinuation of the therapy. So, like, if you don't mind to comment on this, if you.
Yes. So I would say that there are quite a lot of publications showing that the markers are also useful in AOSD. So we have also been trying to collect samples from AOSD and doing research on that. Actually, it turned out to be not that easy to really get samples from therapy naive, fresh patients right at the start, because these patients were initially seen by all sorts of colleagues from different disciplines. So that is sometimes a little bit difficult to do proper research going beyond the translational gap, because what is needed there, I think there's enough data showing that the same will work in an adult patient with Still's disease. What is lacking in my eyes is a validation really showing in new onset patients, fresh patients, a new collection, so to say, independently investigated, that this is really also a matter that can be validated and implemented into clinical practice. But I can only say that in our hospital, I mean, all our patients, also adult patients, are tested the same, and it works nicely and works fine. And I don't see a difference, and I would also not expect a difference. It is rather that and the Still's disease patients in our experience are also not very old. I mean, also the adults, if they are a little bit older, then it is not this initial sign that goes away. It is rather than the T cell components in the end. The mechanism, the autoimmune mechanisms to then find in later phases, they might be different in adults for sure, because they have a different background and different, immune senescence maybe even. And so later signals may be more problematic, but these initial signals, I think, are pretty much the same.
Yeah, so because in pediatric rheumatology, even now in clinical practice here at our center, we are doing in a routine way the measurements of serum calprotectin and even IL-18 levels. Even if we don't have, of course, a validated cutoff, so whatever, but we find it really useful to help us to have these kinds of decisions. And so I think probably we should use more even in adult onset celiac disease as well, because it's not that routinely implemented so far, I think.
Yeah, there's at the moment, there's an initiative, as you certainly know, this PRESS-CARA initiative looking into IL-18 and CXCL9 measurements, because I think compared to the S100 proteins, because they are so routine in IBD, you could use the stool test for serum. I mean, this is what we also did in the past and so on. I think it's very robust, and it's also a matter of the cutoffs. So you need to, it's always an assay specific cutoff, and it changes. So if your assay changes, you have a different cutoff. And so you cannot compare directly. You always need to have the interpretation of the test. In IL-18, to my knowledge at least, there's really no robust test at the moment where you can be absolutely sure about this cutoff, but there's this initiative ongoing. And what I have seen is that the assays work perfectly fine. I mean, any assay, the Luminex, the ELISA, the ELA, they all work fine. They have their strength and their weaknesses. But in the end, I'm pretty sure that we could have an IL-18 measurement. In our hospital, we don't have it on a routine basis up to now. So we need to do it on a research basis, the IL-18. But we want to convince them, because also with the CAR T-cell therapies, so there's a new population. So Still's disease is really not a blockbuster indication for laboratory medicine. I mean, how many patients do you have, they ask, and then why should we implement that? But with the hem-onc and CAR T-cells, and CAR T-cells also for other indications, and the cytokine release syndrome, they need to characterize early. IL-18 is very good to have, actually, and so we hope that we have this marker also in the future in our hospital. And having both is clearly an advantage.
We don't have it either here, the IL-18, so we need to or do it as a research or send it to a private laboratory. So yeah. So we have the calprotectin, but not the serum.
Yeah, but we are getting asked. I mean, people, there's no laboratory offering that on a commercial basis in Germany. And I think this is also in other countries and would be nice to have in the future.
Any other questions?
Thank you for your nice talk. Just a practical question. Fever and rash is a common reason for a patient to go to the emergency department. In your daily practice, which patients should we test for MRP8 as a prognostic marker for developing GI, systemic GI, for instance?
Yeah, you are right. Of course, I mean, we do not test any kid with fever and rash, obviously. So it is, I mean, if we need this entry card of what we would call fever of unknown origin, and this already means you have in the pediatric field, I mean, there are different definitions, but we use at least 1 week. 1 week of fever that doesn't go away. And most viral infections with rash do not last longer than 1 week. And then the typical fever pattern that we can maybe identify, plus we do not do this test up front. So we use CRP, the blood cell count, and so on up front. And if there's a sign of hyperinflammation, of really high inflammation, that wouldn't fit a normal, let's say, viral infection or so, then we would say, okay, now the patient is sick enough for a longer time. And in this case, we would not wait for doing the test. I mean, it is reimbursed in our situation, so it's easy. So we could do it even earlier. It's just that we don't want to overrun the system and do it in any kid, because there needs to be a rationale, of course, and also, yeah, a reason for doing it. But we do not wait long in patients who have fever for a longer while and then somehow also have laboratory signs showing there is really systemic inflammation in place. So we don't, this is not a revolution. We are not skipping all the other investigations and instead using this. It's an add-on. Thank you.